Today we are going to talk about failure of anti-reflux surgery and their management. So we'll be addressing two important subjects today: failure of laparoscopic anti-reflux surgery and also addressing some of the complications of anti-reflux surgery. As you would understand that failure of any procedure is also a complication, and especially when the surgery is done for a benign condition which can be managed by some medical therapy, it becomes even more significant. And we'll also be talking about complications of anti-reflux surgery for uh, GERD, gastroesophageal reflux disease, and their management. So this is the agenda for the day, and we shall be discussing these things in fair details. Now, one must understand the anatomy of GE junction, and one should take, important ideas from this particular understanding to create a very durable surgery for the reflux disease. Here we have shown that there is a lower esophageal sphincter. This is generally having a length of about 2.5 to 3 centimeter. There is an esophageal length which is there in the abdomen, which is about 3 centimeter or plus. So this is a very important information that we should always have, that a length of esophagus in the abdomen is an important ingredient to preventing reflux. And that the length of sphincter is about 2.5 to 3 centimeter. This also is very important because when we create something, we should be mindful of it. And what is the pressure that is present in the lower esophageal sphincter region? That's something above 5 millimeter of mercury. Any pressure that is more than that would be, any pressure that is less than that would give rise to reflux. The angle at which the esophagus joins. So when we are trying to do an operation for gastroesophageal reflux disease, it will be important for us to ensure that there is a length of esophagus in the abdomen, and we would need to do a good dissection, sometimes dissection going into the mediastinum, to make sure that we have a decent length of esophagus in the abdominal cavity. This is length of esophagus which is exposed to the same intra-abdominal pressure as the stomach is a barrier for reflux. Again, three important points that we would need to remember here would be that we should have a good length of esophagus and that we have to restore the pressure. And this pressure, as I mentioned, should be restored in a terminal 3 centimeter or so, and that whatever we create should remain within the domain of the abdomen. So it should remain in the abdomen. It should be about 3 to 5 centimeter length in the abdomen, and creation of a sphincter which will be about 2.5 centimeter. Anything more can be detrimental, anything less can also be detrimental, as we will discuss as we move along. Now, when we do the Nissen fundoplication or laparoscopic Nissen fundoplication, that is the index operation that we are talking here about. In this, we have to wrap the fundus around the esophagus, the terminal part of the esophagus. Now, this is very important to understand, that if our wrap is around the stomach, it's not going to work. So our wrap should be around the esophagus. A wrap which is lower down will be a reason for failure of this operation. And now this fundus has been wrapped around the terminal 3 centimeters to 2 centimeters to 3 centimeter part of the esophagus. after narrowing the hiatus. So whatever we are doing, we want that whatever we are doing stays within the domain of the abdomen. It should not move up. So that is what we have to create. And then when we have done this operation, it is considered to be a 360-degree wrap around the esophagus. And that would be, something which will have maximal kind of uh, maximal increase in the lower esophageal sphincter region. Do we want it? That's also very important. Some of those situations where we may not want that, we have to have a very high pressure in that region, or when we know that esophageal peristalsis are not of good quality, uh, we should not create a physiological barrier to the passage of food bolus. So therefore, we may consider doing a 270-degree fundoplication, which is also called as Toupet fundoplication, where the anterior 90 degrees are left uncovered. The rest of the operation is the same. Fundal mobilization, creating a wrap around the distal most part of the esophagus and securing it with the crust and ensuring that there is a hiatal narrowing that has been done so that the wrap doesn't migrate. So this is another operation which should be there. And the third operation is anterior wrap, which is known as Dors fundoplication. Now, what are the various structural complications which can take place while doing fundoplication? We can have a very tight Nissen, which means that uh, either we have made a longer cuff around the esophagus, or we have sort of created it in such a way that it is narrowing the esophagus. Now, this is important to remember that our uh, wrap should not be more than 2 centimeter. If it is more than that, it can create problem. Second thing is regarding this wrap, that we should have a floppy Nissen fundoplication. And that means that after we have wrapped around the fundus, around the esophagus, lower part, uh, what we should do it over a bougie of 50 to 60 French, so that there is no significant narrowing caused by the fundoplication. We want it to be dynamic, and we want it to be doing something in harmony with the changes which are taking place on the stomach. So if there is a tight Nissen fundoplication, what happens? There are reflux symptoms. No, there are no reflux symptoms because they're very tight. It will not allow reflux. The wrap is intact. If we do any imaging investigations, and we'll come to that, the wrap will be intact in this patient, and there is no migration of the wrap. Wrap is in its position where it should be, and it is not slipped onto the stomach, and there is no recurrent hiatal hernia. That means the gastroesophageal junction has not moved above the into the chest cavity. So all obstructive symptoms, patient will have no other symptoms. And if you do the imaging investigation, we will find that the wrap is intact, but there is causing obstruction. If it is a patulous Nissen, now the patulous Nissen would mean that the fundoplication is very loose. There will be no obstructive symptom, but the reflux symptoms will continue. For the purpose of creating this valve has not been served. The wrap is intact. It is subdiaphragmatic in position. It has not slipped around the stomach, and there is no recurrent hiatal hernia. That is, it is not moved into the chest cavity. When there is a wrap disruption, now what has happened is the wrap has disrupted. Whatever we have created, the sutures have given way. So obstructive symptoms will not be there, but the reflex symptoms will come back. There is no intact wrap on imaging investigation. There is no wrap migration. As it is, the wrap has given way. There is no slippage around the stomach, and recurrent hiatal hernia has taken place. That is, the gastroesophageal junction has now moved into the chest cavity. when there is a subdiaphragmatic gastric slippage,